interesting evolution of this topic of the opioid crisis and kind of our role and our scope of practice. And this is because, now when this is on, I can't see the chat bar, so if anybody has anything, just jump in and interrupt me. But anyway, so I mean, everybody knows, right? This has like been a hot topic for the past 2 years. And I mean, I remember, like, I was trying to think when I was like, it was really 2 years ago in the spring when the CDC came out with those opioid guidelines, and like you started seeing like HHS came out with a statement on it, CNN picked it up, and it started being a hot topic. I was really disappointed in the beginning because I felt like we as physical therapists didn't have a strong presence, right, in that discussion. We weren't really kind of at the forefront of that. It was sort of bothering me. That is not the case now. And so like what you're seeing is a lot of social media stuff, right? And you're seeing like articles about it, but you're not seeing action yet, right? You're not seeing laws change. You're not seeing direct access laws change. You're not seeing insurance policies change. You're not seeing more patients in your practice because of this new awareness of the physical therapist as the alternative to the opioid crisis until now. And what has happened in the last month is in the state of Florida, we have been invited to 3 separate public policy events that have all been hosted by state and local government entities. So these are decision-making bodies. These are subcommittees in the state government, and these are county commission, one county commission meeting, specifically inviting some of the top pain researchers from the University of Florida PT department, specifically inviting the CEO of FPTA, of our state PT association, to come and present at their meeting to help them better understand the role that the physical therapist would play in the opioid, in reducing the opioid crisis. And so what I'm getting now from all of our lobbyists and our CEO and all these people who've been kind of helping us fight these battles for years is they're saying now people care, right? People did not care about your scope of practice. They did not care about co-pays or insurance restrictions or direct access at all until they see now us as a solution in this big, public health policy concern. So we all need to take advantage of that. And I think if you are ever slightly interested in going and being involved at a state or national legislative advocacy type event, all of the states across the country have these, right? We all go to our state capital once a year to lobby the government on whatever our scope of practice issue is. Now is the time, because you're going to start seeing things actually happen, and you haven't seen that over the last decade. Now, I've been in practice for almost like 11 years. I've never, ever, ever seen a time where people were actually inviting us to come and speak and present and looking at us as a solution. So I think that's huge. In case I was talking to some students the other day, and they were get everybody. Oh, highly recommend a documentary Netflix called Heroin. That's cool, Al. No, thanks. I'm gonna check that out. Yeah, thanks, Dan. The hurricane is gone now. We are getting back to normal now, so that's good. But I was talking to some students the other day, and I presented this slide, and I was floored that the number of them that didn't know this. I'm sure most of you know this, but we kill more people in this country from prescribed pain medication than cocaine and heroin combined. So the blue line is number of cocaine deaths per year. The green line is showing you number of heroin deaths per year. The red line is prescribed opioid analgesics. So, people taking pain relievers for back pain or post-operative surgery, from a surgery they probably shouldn't have gotten in the first place, from dental procedures, you name it. These are prescribed opioid analgesic deaths, and obviously that number's trending. I'm sure you guys have seen those statistics. So a good opportunity, I think, for us. And this is definitely exciting times. All right, we're going to get into the hip. We're going to cover a lot. My goal tonight is for you to leave here feeling like you have a lot of new ideas, new concepts. You have some exercises that you can implement in the clinic for patients with hip conditions. I really want to leave you with a lot. And I really hope that over the next week or 2 weeks, I'll check Facebook a lot. And I really hope that you guys will bring, your challenging hip cases, hip dilemmas that you have. Let's really focus Virtual ICE on over the next 2 weeks on the hip. And let's share all of the knowledge that's out there, research articles, stuff like that. So I'd like to see a lot of good post-presentation discussions. I'm going to start with the end process of end-stage hip disease, which is really degenerative joint disease, right? And I would present this to you as sort of like in the way that you would play pool, right? The difference between somebody that's good at pool, billiards, and somebody that maybe is not, one of the key differences is people that are good plan ahead, right? So people that are good are looking at not the shot that they're about to take. They're looking at 2, 3, 4, 5, 6, 7 shots down the road, right? And they're planning those shots and they're considering those shots. And so that's the way you need to look at the hip. Hopefully you leave with this tonight as that 35-year-old patient that presents with lateral hip pain that you believe to be soft tissue or tendinopathy in nature, that you understand that this is a case of initial onset hip DJD. And it's not an isolated case of tendinopathy. And there are key management strategies that you can integrate now while the patient is young that will hopefully prolong the life of that hip and prevent the onset of degenerative joint disease. So that's kind of really needs to be our focus. So when I present on degenerative joint disease, don't think of the 75-year-old patient with full-blown, severe osteoarthritis of the hip. That's not really who we're targeting. I mean, it is. We'll treat that patient. But where you're really going to make an impact is going to be the 50-year-old, with that kind of vague hip synovitis or maybe soft tissue injury that's going to eventually lead to joint disease down the road. Same thing with chest. In case you didn't get, in case the pool analogy was not enough, maybe some of you are into chest, the same idea applies, right? Planning out a long-term strategy and looking 4, 5, 6 moves down the road and how are you going to handle this patient? How are you going to educate this patient to really reduce the likelihood of a total hip later on in life? It's important to look at this like once a hip OA case is diagnosed, it is moderate to severe. The only way you're going to see pathology on imaging is when it's in the moderate to severe phase. Now, I get it, pathology and pain don't correlate, and oftentimes people with very mild joint changes won't present with any symptoms whatsoever, but you can assume that your patient with a concomitant hip pathology likely is going to begin to have pathomechanics or early onset degenerative joint disease at some point after that injury. Right? That's one big thing about the hip is the hip, all the body doesn't forget, but the hip really doesn't forget those old injuries, right? The hip will start to stiffen up, it'll get weak, and it'll start to break down a little bit. All right, before we get deep into this, let me check the chat box again. All right, cool. Stop me. Definitely do not wait for your questions at the end. If you just interject and say something, I'll hear you, and I'll stop talking, and I'll field your question as we go. Don't feel like you gotta wait till the end. Okay. So look at the right side. The sequela of hip osteoarthritis. This is the way you begin to look at it. I begin to have hip pain, or I begin to have some type of hip injury, right? it results in potentially maybe muscular inhibition. We know that with hip pain, glute musculature will get weaker, right? So maybe you start to lose some glute strength, glute max strength. That may then result in a loss of mobility. You don't begin to use, you don't use your full range of motion anymore. We see with hip osteoarthritis all the time a thickening of the capsule, capsular changes, where we get a loss of mobility in the hip joint capsule. That then results in cartilage loss, right? Cartilage wear and tear, because now you have a more focal wear pattern on the hip joint, right? If I'm not using the full amount of range of motion, then certainly I'm going to wear down certain aspects of the joint tissue more than others. And that's really a cycle, right? As I lose cartilage, I get more capsular fibrosis, I get more loss of mobility, I lose strength, I have more muscular inhibition, I lose more cartilage, I get tightening of the joint. So it all kind of snowballs and really is the primary mechanism, right, of pathomechanics and joint breakdown. Your primary, age group, these individuals are primarily going to present over the age of 60. I'll present a case to you tonight that is in a much younger patient. And there's a lot of younger patients that have injuries early in life, possibly developmental disorders, obviously dysplasia of the hip early, as a baby is going to predispose you. But prior hip injury is your big one. Not just hip injury either, knee injuries, right, ankle injuries that can result in kind of faulty mechanics of the hip. You can diagnose hip osteoarthritis, hip degenerative joint disease without a radiograph. Like I said before, by the time they get a radiograph and it shows joint space narrowing, it shows sclerosing in the subchondral space, or it shows osteophyte formation, it's too late. It's too late. That's full-blown hip OA. That's severe hip OA. Most patients will have mild hip OA undiagnosed with plain film radiograph. Now, the physical exam that I'm presenting to you mostly correlates with radiograph positive hip OA. So this is, again, the severe case of hip OA, but I just want you to take a step back and just think about how a patient with a less severe case of hip OA will present. We'll talk about that at the end. But you see your 4 criteria right there for a diagnosis: weight-bearing pain, age over 50, morning stiffness that improves in under an hour. That's important, right? It improves in under an hour. Once they start moving, that hip joint tends to feel a little bit better. That's a clear-cut joint cartilage issue. And they've got a mobility loss, right? So they've got at least a 15-degree loss of flexion and internal rotation compared to the uninvolved side. Or if they just have internal rotation limited to 24 degrees, that still makes them positive for a hip OA diagnosis. This is a pretty strong diagnostic cluster that you can do. It was initially presented by Altman in 1991. It's been validated by a few groups since then. And you can see the metrics there. It's fairly okay, right, at diagnosing, ruling in, and certainly good at ruling out hip joint pathology or hip joint degeneration. Okay, full-blown hip OA, we will have a fairly comprehensive physical exam in history that
Hey, Eric,
is going to include...
RJ has a question.
Yes, please.
He asked, does it matter if the internal rotation is testing in sitting or prone to be less than 24 degrees?
That's a good question. I'd have to look that up. I have the paper, the original Altman paper that looked at that, and I'll be able to post that on Facebook for you guys later. I think I have it tested in prone, but I'm not sure that that's what the original paper described, so I'll look that up. Other questions about hip OA diagnosis? And I would, yeah, no problem, RJ, my pleasure. I would also share the idea that if you're getting a decent number of patients with late onset or moderate to severe hip osteoarthritis, the clinical practice guideline for hip OA was just revised maybe 4 or 5 months ago. It was earlier in the spring, like May, in JOSPT. It's just such a nice, all-encompassing resource for everything that we would ever want to know about this condition and the management of this condition. So it's a great one for like journal clubs and stuff like that. But I'll get the specific IR mobility testing for you. Functional measures. So we'll couple some type of patient self-report measure along with a physical exam, right? That's critically important to measure change. So the WOMAC is really the most prolific. You're going to see that in most of the osteoarthritis trials, and you'll see about a 9 to 10 up into a 20 MCID, depending on the population that you look at. So in order for you to really justify true change, positive outcome, you got the patient better, you need to be at the upper end of that MCID, right? I need to see at least a 20-point improvement on a WOMAC to be able to be satisfied from a self-report sort of, I guess research metric of functional improvement. And then the LEFS, if you're just giving that to everybody, I mean, that's a nice quick way to do it. You want to see about a 9-point improvement on the LEFS. I always share this with everybody anywhere I teach, and the Ortho Scores is such a nice website. If you don't have photo or you don't have electronic patient self-report measures in your clinic that you're using, if you have a laptop set up in your clinic or you're using some type of electronic device for intake data for your patients, you can literally just go on Ortho Scores, have the patient check the boxes for the self-report measure you want. It'll auto score it for you, and then you can print it or save it as a PDF. So that's a nice, really nice free resource that's out there, orthopedicscores.com. And they've got pretty much every self-report measure you could ever want to use in an outpatient ortho environment. That's the prone IR there, but I'm not sure if I just did that because I'm used to doing that or if that is reflective of the original Altman paper. But anyway, bottom line is you got to see about a 5-degree minimal detectable change, for your range of motion data to be happy. And we're usually measuring pain upon range of motion, right? That helps a little bit with our kind of tissue irritability understanding. And so when I take them to end range like that in IR flexion with the inclinometer, I'm asking him at end range, how much pain do you have there? And so a 2-point, improvement on the pain scale when we take them to end range like that, that would exceed minimal clinical important difference. You'd be happy with that as far as meeting the threshold of measurement error. Mobility is key. Mobility is key. And so this is, I think, where in your early onset, your minimal to mild hip osteoarthritis, it's not super obvious yet. It's the loss of mobility is my biggest focus, right? Biggest focus. Loss of mobility and strength, obviously. It's the simple stuff. You got a couple different ways to measure strength. A simple supine kind of brake test with a handheld dynamometer would work good. That's a nice way to measure side-to-side differences and get a relatively objective strength measure. I know those things are expensive. Those little handheld dynamometers cost $900, but that'd be a good solution. If you don't want to spend that kind of money, then I love having the patient perform a specific exercise that I believe relatively isolates a muscle, and then comparing that bilateral for a rep max, right? So standardize the weight, compare bilateral rep max. How many repetitions can you do, say a supine hip abduction with a yellow TheraBand around your ankle? How many repetitions can you do, compare that left versus right, as a really low-level, easy strength assessment? There's a number of ways you can do that. And then measuring irritability with something like the Faber, right? So I want to have some determinant of irritability of that hip, because it oftentimes is a key guide, key decision-making tool for treatment progression, right? Once his hip is less irritable, I'll be able to get more aggressive with both the manual techniques and the exercises. Easy little Faber test, and quantify that with an inclinometer. And then in the older population, gait speed is critical. Gait speed must be part of the physical exam. It tells me safety. It tells me fall risk, right? I can learn so much from gait speed. It correlates well with the Berg balance scale, which is so nice because you don't have to do a long, involved 10-minute balance assessment. You know, a simple timed up and go. How far or how fast can you walk 3 meters, turn around, walk back, sit down in the chair? You know, can predict long-term disability. It can predict fall risk. Fall risk is about 13 seconds. You want to see them faster than 13 seconds. Long-term disability, you want to see them at under 9 seconds. These are nice discharge metrics for me, right? I don't really want to let him go until I can get him his gait speed up till he can do a tug in under 9 seconds, because I know that impacts long-term outcome. And if I want to prevent a total hip and I want to keep this guy out of the hospital, I got to get him at a relatively normalized gait speed. I'll stop there for a second in case there's any questions before we get into the treatment stuff. Why do they always wear jeans? It's fun. And in Florida too, you would think people would wear shorts in Florida. It's hot. It's hot. But all right. All right, symptom modification procedures. So you guys know we're coupling the physical exam, right? These impairment-based measures that we know correlate to long-term outcome. We know range of motion, strength, gait speed, and then the functional self-report measures all correlate to long-term outcome or correlate to prognosis, right? Symptom modification is really going to do the same thing, but at a different mechanism, at a different angle, right? Because it's really specific to what they came in for, which is why I love symptom modification so much, because most people, 99% of these patients, right, they're there because their hip hurts and they want you to take care of that. They want you to get their hip to not hurt anymore. So if you can do something in the clinic that immediately reduces their pain or even abolishes their pain, that's a huge winner. It teaches the patient, it shows the patient that you know what you're doing, that you have the ability to reduce their pain immediately. That's huge. But it also tells you what type of treatments they're probably going to respond well to, right? So I'm going to do a battery of manual therapy tests, not only long axis hip distraction, a number of them. I mean, pick your favorite mode, whatever it is. You know, I'm going to mobilize that hip, especially if it's stiff, and I'm constantly asking them, does this change your symptoms? Does this change your symptoms? And I want to determine, you know, which technique or do any of these techniques reduce pain. 2-point improvement on the pain scale is a winner, right? You know that. I mean, so you might not only just say, does it improve your pain, but how much, right? If currently he's at a 5 out of 10, what's your pain level now when I pull on your hip like this? I will oftentimes apply some type of mobility, some type of manual therapy technique that you believe is hypoalgesic in nature, whether that's a joint mobilization, a soft tissue technique, whatever it is, with some type of mobility intervention. So the patient that you believe is going to respond well to the manual therapy is going to have a reduction, it does have a reduction in symptoms when you apply the manual therapy. The manual therapy is just creating a window of which you can now intervene to improve their overall mobility, right? So never am I going to apply the manual technique and then just kind of watch them, you know, feel better, right? It's apply the manual therapy technique. What's your pain level now? Oh, it's down to a 2. Okay, good. Now I'm going to be able to start working that hip, you know, from a mobility perspective. So this is a good example here. I've got a highly irritable hip. I'm applying, I'm not doing it actually, somebody else is doing it, but applying the long axis distraction and then chipping away at that hip mobility with a little bit of a hip flexion movement like that. Never biting off more than we can chew, right? The key to this is that it's tolerated well. I'd much rather the patient leave and all I did was gain a simple little 8 to 10 degrees of hip flexion, but they feel better and I can chip away at it more next visit than try to gain 20, 25 degrees of hip flexion, but flare them up, right? Obviously, it's not going to go as well. So think of manual therapy as creating a window of opportunity for you by which you can intervene with other mobility interventions and strengthening exercise. Then progressing that to some type of self-mobility intervention. I really want the patient to be able to do this on their own, right? That is key. So whatever mobility exercise you found that is helpful, if you can teach them to do it and have them maybe use some type of external device or some type of a strap or a belt or a towel, whatever, get them to do some type of self-mobility intervention that can reduce their symptoms, abolish their symptoms, give them a post-stretch 2-point pain score reduction, or even just simply a little bit of a range of motion increase, to me that's a winner. If I can get between session changes in pain and mobility, then that's a real winner. So those are the things you want to look for when you're prescribing some type of self-mobility intervention. I want them to feel better. Remember, if you give somebody something that makes them feel better, especially immediately better, adherence goes up, right? Adherence goes up. The best exercise is the exercise that the person's going to actually do. To get somebody to actually do something, you really want it to make them feel better. That tends to work well. When they have high irritability, you might just consider, obviously, not being as aggressive, but short duration, little repeated bouts. Think of the high irritability case as the one that you really got to tease that pain out of the joint. Light, frequent, but short in duration movements. They can kind of finesse the pain out of the joint a little bit. This is just some overall principles for your mobility interventions. Generally speaking, we want to hold these stretches at least 6 seconds. That's the smallest duration of time in any research study that's been shown to be effective, up to 2 minutes. The older you are, though, the longer you want to get the hold. So over 60 seconds for the older adults tends to be where you need to be. Long duration holds to really get that movement better. But I would say you're really looking at that from an irritability perspective, right? When they're feeling better and they're tolerating it well, that's when you're pushing it kind of hard over 60 seconds like that. When they're not feeling so good, you're using the shorter duration. And then following that with active exercise, I'll show you some exercises now that you could follow these strategies with. Key thing for the mobility exercises is they don't give them any pain, right? Maybe they have a little discomfort, but 24 hours post-exercise, they should be back to baseline, back to their baseline level of pain, not flaring them up, obviously. All right, we're going to get into some glute exercises. Let me pause again. Alan or anybody, any questions or comments about any of that? No, keep
Eric,
going.
what's the author of that article looking at hip internal rotation?
Oh, the Altman. So this is you can see my screen, the Altman is the corollary study that looks at the cluster of physical exam measures that correlate to radiograph, positive OA on a hip radiograph. But there's been some newer studies that have come out since then that have looked at this as well. So I'll post links to those on the Facebook page. All right, other questions? All right, get into the glutes. Glute muscular weakness. So in knee pain, we see quadriceps get weak. In shoulder pain, we see the external rotators get weak. There's this, like, you hear people talk about glute amnesia or glute inhibition, and does that really occur? Probably not, but if you've ever seen somebody with really bad ipsilateral hip OA, you will notice a marked difference in hypertrophy of the glutes one side to the other. So you do get gluteus weakness. We do have a good deal of research that shows reduced EMG activation and reduced overall strength output in patients that have hip pain. We're going to primarily focus here on gluteus medius and gluteus maximus, and really the muscles that people tend to overcompensate when they have weakness there, which is the TFL and then the hamstrings. So for the abductors, you want to, this obviously is a really easy, simple, low-level exercise, and the key is just that the person's going to be able to tolerate. So this is going to be like worst-case scenario, right? The person with a highly irritable hip, unable to really tolerate a whole lot, relatively deconditioned, relatively weak. Just having that simple, light abduction type of a movement like that to try to facilitate movement of the joint and really just get that glute max to start contracting and start exercising a little bit is the goal. Adding load is easy. What you love about this, right, is that it's somewhat hard to screw it up, right? They're in supine. It's not a complicated movement. They're sliding their heel on the table. They're typically not going to compensate all that bad. So it's a nice low-level exercising, get a nice quad contraction as they lock out the knee if I'm working the kinetic chain and get things going there. Same thing then with the bridge, right? The bridge is kind of that classic hip glute max exercise to just initiate things. I want to just get glute activation. I just want to begin to initiate and get them to try to control them. The problem is usually they'll overcompensate with their hamstrings, right? And the older patients, most of your geriatric patients, are going to have a cramping. Have them abduct like that. So the way that he's abducting his knees, his hips like that, is going to really inhibit the hamstrings. So that glute max to hamstring ratio is dramatically improved when you abduct the hips like that. And try it on yourself sometime. You palpate your hamstrings doing a regular bridge and then abduct a little further out, and you'll notice a reduced contraction of the hamstrings. And there's a, I think I have it cited there. I just can't see. There's an EMG study that looked at that Kang 2013 study. That group out of Asia looked at that, and they compared EMG activation, hamstring versus glutes in all three positions. Neutral hip, like 15 degrees out, and then I think 30 or 45 degrees out. The further you were out into abduction, the less hamstring activation you had. So it is valuable, I think, to have them almost maximally abduct and even abduct against resistance, like you saw him doing there, which can be helpful. All right, clams are, I used to always not see value in the clam. There's a ton of value in the clam, primarily because of the coupled external rotation movement, right? So side-lying hip abduction would be what a lot of people would probably advocate at some point here. I'm not advocating for that just because you get so much TFL activation, right? So people will compensate with a side-lying hip abduction. They won't compensate as bad with a clam because you have that coupled external rotation movement with the abduction. So feet together, hips at about 45 degrees of flexion, and we're just going to spread the knees apart, right? Go out into that clam and try to get them to not roll back. But that'll give them a really nice burn. That'll initiate glute med and glute max because of the external rotation component. And then this is the clam plus. You're having them take that top femur, that top part of the hip, and you're having them push that forward. So you see how he kind of juts that top femur forward. I'll put my hand in front of his femur, like right here, have him tap my hand. So he's kind of reach forward with that femur. And what that's doing is preventing the rollback, but in an active way as opposed to passively holding him and preventing him from doing the rollback, right? So that's really nice. Do set a 30 of those yourself, no weight at all. You'll feel a pretty significant burn in your glute med. Great little relative isolation exercise. You're not completely isolating glute med, but you're getting close, about as close as you can get to isolating glute med with that clam. But that's valuable early on, right? Early on, when I've got this inhibition problem and he's compensating with all these other muscles and his pathomechanics are at their worst state, that's when I really want to try to do these isolated specific movements and initiate muscular contraction. Fairly quickly, though, we will, progress them to functional movement, cardiovascular movement, start working on their endurance. A repeated sit to stand like this is just such an excellent exercise. Those of you that aren't practicing in outpatient, maybe you're in a skilled nursing facility, home health, acute care, and you're looking for ways to elevate heart rate, get some type of kind of functional endurance exercise. This is such a great option, right? This is when they're going to fall. they're going to fall during a sit to stand transfer. That's when they're most vulnerable. So training that movement in the safe environment of the clinic and getting them more confident, stronger, and having better endurance is key. And I like to time this, right? So you can time it. How many can you do in 30 seconds, like a 30-second sit to stand test, and then progressing them, right, with both time and volume, speed. Squatting, right? Squatting at a sink like that. The sink is nice because it gives her something to grab onto. She can curl her fingers around and really hold on to that sink, which really allows her to sit back. So I'm gonna get a lot more hip flexion. I'm gonna get a lot more glute work if I can get her to sit back like that, maybe even look up, right? Keep that trunk relatively upright. Use those glutes, really sit back to maximize the glute strengthening aspect. Okay. Step-ups. Step-ups would be a nice next progression, because if I want to start working that glute strengthening, right, I want to do it in increasing levels of hip flexion. And so the step up is nice because I can elevate the amount of the step by having an increasing level of a step. He has to kind of swing through. So there's a balance component of it. He's got to use that glute med to keep his pelvis level, right? So there's that kind of core stabilization aspect of it. So many ways that you can progress this by having him do movements with the other leg, with the arm, having him hold weights in his hand to add load to it. And like I said earlier, add elevation, right? Size of the step can help also. More sit to stand. Cannot stress enough the importance of cardiovascular training, right? There's a hypoalgesic effect. If I can elevate your heart rate for 20 minutes during the PT session, there's going to be a hypoalgesic effect to that. If I can get you walking on a walking program or some type of biking, or whatever I can do to add aerobic capacity training to resistance training, I'm going to get a better outcome, right? It's a more holistic approach, and I'm integrating more of the body systems and probably going to get a better physiological response. Any questions at this point? That is the hip OA, the degenerative side of things. I'm going to get into some other conditions now, but I'll tie these back into kind of early onset hip OA and how you need to think about these conditions as predictors or prerequisites to hip osteoarthritis later on.
Hey, Eric.
Yes.
After you're mobilizing for internal rotation, are there any specific exercises you like to do for that active internal rotation?
Oh yeah, IR specific exercise after mobilizing. Yes, while we're talking, I got a few of them later on that I want to show you now since that is relevant. So you can actually get a relatively decent self-mobilization of IR with this one. So she's standing, right? Knee on the table. I can have her kind of almost weight shift a little bit and self-mob that hip kind of into abduction a little bit. I don't think that actually does anything, the self-mob part, but whatever. Maybe it like encourages her to move a little further, or maybe she gets some type of hypoalgesic response just because of the tactile input. But if you preload the hip into IR like she has there, that'll give you a nice little self-internal rotation mobilization that you could follow up. So like, that was Alexis, right?
Oh, it's Sarah.
Oh, Sarah. Different Morgan.
Yep.
So if you self-mob, if you did like a mob with a belt, right? You've got her in supine, you put her into IR, and you're using your belt modes. Following that up with this is a really nice self kind of mobilization stretch that I might consider, and then I follow that with this kind of active external rotation exercise. So that's a nice little 3-step intervention that you might consider, from a manual therapy technique to a self-mob to an active IR exercise. I'll show you the mob. I have that mob in here. So like with the belt around your body and that patient's hip, right? Pull lateral, but put the hip in internal rotation there like that. That's a really nice mobilization. I'll mob him into IR, then have him do the self-mob and then the active movement. Mark Miller, oh, that's funny. That's my neighbor. The guy in the bro tank is my neighbor. All right. Non-arthritic hip pain. So all your other hip joint pathologies that aren't yet that bad, right? You pretty much call them non-arthritic hip joint pain. Most people think of FAI, femoral acetabular impingement, cam lesions, pincer lesions, right? So there's some type of approximation or pinching, if you will, between the head of the femur and the acetabulum. But there's a lot of other non-arthritic hip joint issues that we're seeing that probably aren't that obvious, like synovitis, right? Just a deep ache in the hip joint just because that hip is flared up. Bone bruise would be another big one, right? In some of your relatively like even low energy trauma cases, you get that subchondral bone edema, right, on the head of the femur or even on the acetabular side, and that's very symptom producing. Young person with weight-bearing hip pain, more than likely some type of synovitis or subchondral edema, right? Subchondral edema actually does correlate fairly well MRI to pain severity. It's one of the conditions, one of the rare conditions that actually does have some decent correlation, particularly in the spine. But anyway, these labral tears are going to be a little more obvious because it's going to be clicking and popping in the hip, right? You're going to notice that specific pinch. The problem is the diagnostic tests we have not really held up. So maybe the greater clinical picture looks like a hip labral tear because of the history and everything else. But getting a specific diagnostic test that's going to really truly rule it in for you is a little bit more challenging. We'll also get into kind of treatment in this case, a little bit of some of these soft tissue injuries. So like this is a snapping psoas syndrome or a psoas tendinopathy or some type of psoas muscular strain. That'll mimic this non-arthritic hip joint pain as well because it's such a deep tissue, right? Should have that specific hip flexion pain reproduction, but it sits right over the joint. And a lot of times it is hard to discern between a labrum tear and some type of snapping hip syndrome or psoas pathology. You can do this flexion, adduction, internal rotation test. It's actually kind of a crappy test to rule in FAI and hip labrum pathology. What it is decent at, though, is ruling out. So if you've got somebody and you want to rule out, you want to make sure they don't have this non-arthritic hip pathology from a labrum tear or FAI, then that flexion, adduction, internal rotation test is actually halfway decent at that. You're just putting them up into flexion and kind of sweeping the hip, moving that hip into adduction while you internally rotate it. A lot of these patients will have tightness or loss of mobility for both IR and ER. That's kind of a hallmark sign, probably because of swelling in the joint. It may be due to the actual cartilage pathology, but a lot of times they are restricted in their movement for rotations and flexion. Most of these patients, right, they're going to have some type of joint mobility issue. They're going to have some degree of hip musculature weakness, a 28% reduction on average in hip extensor strength, abductor muscle strength, right? So it's kind of like hip OA. You're seeing sort of the same type of impairments correlated with it as far as strength and mobility. The big one about this, though, is you always think about this for all hip conditions, but the position of the acetabulum is completely dependent on core control, right? So their ability to control their abdomen and their pelvis, motor control of the proximal aspect of this region is really going to dictate a lot of these different pathomechanics. And so I'd address, right, transversus control, rectus abdominis control, looking at the obliques, looking at the lumbar multifidus. It's all going to play a role, obviously, in hip pathomechanics for FAI. It's a nice little symptom modification procedure. So sometimes these patients feel good going into abduction, external rotation. I would like to know if it feels better when I apply a load. If it feels better when I apply a load, it's probably, a lot of times, you know, kind of helping me rule out soft tissue and more thick, non-arthritic hip joint pain, FAI, hip labrum, right? This typically doesn't give them pain because you're moving into abduction, external rotation. You're not really creating that reproduction of that pinching. And then obviously then it's gonna be prognostic. The patient's probably going to benefit from some type of abductor extensor strengthening program. So here's a good example of kind of just integrating, right, that core and hip control. So anything that you can do that'll both give you a gluteus maximus control, gluteus medius, right? She's having to use her right glute max, glute med to keep that hip in that position. So using her right quad while at the same time kind of perturbing her core with the band moving into shoulder extension like that. So I'm kind of getting that left lat along with that right glute. She's going to use her obliques to come back. I can work core control, transversus, and all that with that. So integrated exercises that integrate both the hip and the core are going to be valuable for these patients. A couple of manual techniques. So these guys will really benefit from extension mobilization. Right? That's going to make them feel better. The psoas, the snapping psoas or the psoas tendinopathy may have a reproduction of symptoms with this. But sometimes it like a hurts so good, like it feels kind of a relieving almost stretch. I really want to know the result of this mobilization from a symptom reproduction or possibly symptom modification perspective. So great little symptom modification procedure there in prone, couple pillows under the stomach, move that hip into extension like that and get an idea of how that changes their symptoms. Not just from a mobility standpoint, but also from a symptom reproduction standpoint. It's valuable. And then following that up, right, with some type of active extension exercise. So you'd use the same stuff we showed earlier. Maybe you'd use a bridge, maybe in a single leg bridge. But this would be a nice way to integrate kind of that spine, core control, rotational mobility of the spine, along with that hip extension mobility and hip extension strengthening. This is a relatively higher level exercise. I might not jump into this in the first few visits, but once you got somebody that's kind of high level or they're doing well with the hip extension work, this is a good one to progress to.
Eric, Ashley asks, are there any other options for different hand positions to decrease wrist pain for prone mobilization?
That's a good question. You know, it's funny. I haven't played with that too much, but I feel like I have had wrist pain while doing this. I gotta think, and I think I might subconsciously do this, your amount of wrist extension doesn't need to be as extreme, right? I could potentially rotate her hip a little bit. In this case, maybe I rotate her a little bit into internal rotation. So I bring her foot kind of towards that wall that's behind him, right? And then I don't need to push down with my body weight over top of her with that much wrist extension. I also kind of wonder about, like, if you're getting ulnar-sided wrist pain, like how much ulnar deviation are you in? Can you load your radius a little bit more? I mean, I don't know. Like, an open hand to me is going to be kind of the main method here. I can't picture using any other type of hand contact, but I think you can alter wrist angle via either her hip angle or your body position. Would love to hear if anybody else has other suggestions or techniques you guys use. Let me just read real quick. Oh, thanks, Alan. Man, you are on top of it. You just did it right now. Altman's criteria: prone knee flex 90 degrees, pelvis stabilized on table. That's like the way that I had in that picture. All right, so forearm. Yeah, I guess, Sarah, that makes sense. Just kind of lean on with your forearm, the meaty part of your forearm. Shoulder of tension with that position. Zach and Alexis, flip my hand around the opposite way and go laterally on their femoral head, as Morgan said. I got to see a picture of that. That'd be a good Facebook post. Show us a picture, Zach, of or Alexis, of that technique. All right, other questions? Opposite of what's shown in the image. Oh, I see what you mean. So you're just supinating your own forearm, basically. That makes sense. Supinate your own forearm, and you're kind of more on that lateral side. All right, what about these ones? Let's see what you guys think about these. So these are kind of the classic belt hip moves that you would use, where the belt's around you, the belt's around the patient's hip. Try to get it a little more proximal than that. Get it, as deep as you can in the hip, and then put a little towel around his hip to keep him comfortable. But what I love about these is the fact that you can add so many different movements with it, right? So I can change the flexion angle, I can change the rotation angle, I can do movement with it, right? I can add that lateral stretch while I'm kind of moving him into those different positions. So these are some really nice. You'll see, I'm sure a lot of you guys do these already, but if you haven't, you'll get dramatic range of motion improvements with these hip belt moves. I'm changing the angle here for more of an inferior directed pull. Right here, I'm doing more of a laterally directed pull, kind of pulling that hip straight out to the side. For flexion, usually you want to go a little more inferior, so I'm changing the angle, moving my hips a little more down towards the foot of the table and kind of pulling them straight inferior with that belt like that. And then he can do it himself too. He can do it himself with a band like that. This is hard to set up. If you've got kind of the apparatus for it, you've got one of these thick sort of big bands like that. This is a nice way because it gains tension as he brings the hip back. Earlier I showed you one where you just simply rolled up a little weight or a towel in the hip, and that tends to work nicely as well. I'll follow up those belt moves with this. This is just a cuff weight that's used as a fulcrum. Kind of roll that up, put that in the crease of the hip. As she flexes her hip up like that with that self-stretch, it'll give her more of a focused stretch. A regular little hip flexion stretch like that primarily is really targeting her lumbar spine. It's pulling her pelvis into a posterior pelvic tilt, really. By putting something in the crease of the hip, you kind of focus the stretch more on that hip flexion mobilization like that, which is nice. All right, and then critically important to get up to weight bearing, right? So this might be a little much for some people, but a relatively higher level patient. The supine hip flexion really doesn't mean anything. That's an important concept, right? If I don't integrate some type of weight-bearing hip flexion movement like a deep squat like that, now not everybody's going to be able to tolerate it, but if I can get away with this, I really want to try to integrate that weight-bearing deep hip flexion position like that. He's kind of locking out his spine in this case, and then here he just gets into that deep hip flexion position, holds it, right? And I really want him to feel where his bottom is. How deep can he get into that hip flexion position in a weight-bearing position comfortably? Maybe you have him put his elbows between his knees and kind of spread his hips into abduction a little bit more, but really get down there. That's going to be a nice prerequisite to your exercises because now he knows how deep he can get, right? And so when he does his loaded squats or he does his deadlifts, he has a much better sense of how able he is to get even deeper than what he was probably doing before. Hip extension is tricky from a self-mobilization standpoint. It really is tricky. This is one of the better ones, though. It's same thing, a little challenging to set up logistically, but if you put that band around his proximal hip, it's just below his glute, have him do a little bit of a fencer stretch and kind of hold that while he's contracting his abs like that, and he can work that extension like that with kind of the facilitatory help of the resistance band. All right, so we touched on this earlier, but that focus of abduction, external rotation, and extension while minimizing the compensation from the TFL and glute max is kind of our focus. And this Selfkowitz study is kind of a neat EMG study where they compared several different hip exercises, and they looked at the comparison between the glute med and the TFL. The higher the number gave you more of a glute med and lower a TFL activation. So you can see how well the clam does with that because of the external rotation component. Side step, not so much. Step up, this is all just because really compensation of the TFL, which, I mean, we're big proponents of these more functional exercises that you're going to be able to load and actually make changes. But early on, if you're trying to kind of restore pathomechanics or reverse pathomechanics, you don't want compensation, then the lower level isolation stuff might be a little better. Side plank would be a nice progression too right here, is I can have her elevate and bring that hip up, that pelvis up, while hovering the opposite knee like that is really nice to isolate that left glute like that. I'm also getting a lot of good core control, so that same issue of kind of femoral acetabular impingement, their labrum is giving them some trouble, some irritation. I can control pelvis position by having her contract her abs and work her QL and her transverse abdominis while she's loading that left glute med, which is nice. You can add perturbation. You can add perturbation to anything, right? Perturbation gives you, the therapist, a better sense of what they're able to control because you can tactilely feel how the patient's able to meet your resistance or sustain your resistance, your perturbation. There's a tactile input component of it. There's a hypoalgesic response, right? Because I get that little manual therapy kind of touch, therapeutic touch aspect of it. And it kind of makes the rehab a little bit different, a little bit fun, right? It's something that the patient cannot do on their own, so it adds maybe some value to the program. So a little bit of hands-on perturbation is really nice for a number of different exercises. A great example here. She's kind of having to hold herself in that plank position while you give her perturbation through the trunk. Sidestepping. A lot of value in this exercise because of the concomitant quadriceps, hamstrings, glute max, right? It's just a nice kind of lower extremity sort of general exercise that is functional in nature because I'm working balance, right? He's working his hip abduction mobility as well. You probably don't want him to wobble his trunk that much, right? That's a bit of a compensation. I'd like to see him kind of keep a little more level shoulders and really isolate those hips as he comes out. The Berry study that came out a couple of years ago, they looked at glute med and TFL EMG activation in both a knees straight position and a slightly knee flexed position, 15 to 20 degrees of knee flexion. So like the mini squat position. Mini squat gave you a much better glute med to TFL activation index than knees locked out. Knees locked out, you tend to compensate with your TFL a little bit more. So just something to consider, making it more of a mini squat side step. More perturbations. So leg press is such a nice way to really get an objective measure of strength, right? So same thing before. If you don't have that handheld dynamometer, but you do have some type of isotonic leg press machine or hip resistance machine like that, I can get a side-to-side comparison. How many reps can she do with a standardized weight for a leg press, comparing each side? And then I can also obviously add perturbation with it like that too. So one of the big things is when she'll be able to do a bunch of clams, she'll be able to do a bunch of bridges, side steps, no problem. But then as soon as she squats, she still collapses into a valgus. She still is unable to control the femur. So the more you can couple quadriceps loading exercises along with glute control type of exercises, that can be a nice strategy. more core kind of integration type of stuff, right? I could add an active lunge. She's just sustaining the lunge hold there, but I could add an active lunge to that, have her rotate with resistance at the same time. So now, you know, if she had that interrotation flexion-based pain, this would be a nice way to start getting her back without aggravating her too much. As she rotates to the left, right, that's kind of forcing this hip into internal rotation inadvertently. So I'm getting sort of an inadvertent hip internal rotation through the opposite trunk rotation. It's really nice for people that can't tolerate loaded rotations yet, is I'll just work top down first, right? Kind of work the trunk into rotation against that direction. There's the active one. So that would be the progression, right? Instead of a sustained hold, have her actively lunge, load that glute just before the provoking symptoms come on, and then rotate into it like that for the obliques. I feel like I haven't stopped in a while. I should check on you guys. Alan, we get any questions? I'm not wearing a short sleeve lab coat. My sleeves are rolled up. Short sleeve lab coat are for pharmacists, not physical therapists. All right. No other questions? Okay. All right. Deadlifting is the key fundamental movement. It gives us a great awareness of hip mobility, isolated hip movement. It teaches the patient to use their hips, right? Maybe not compensate with their spine or their knees. It's great for everybody. I mean, I think you can make tons of arguments of the benefits of deadlifting, and you don't have to always heavy load deadlift, but I want to teach most people how to do this dowel deadlift because I like them to isolate their hips like this in sort of a weight-bearing fashion. So the dowel deadlift, most of you are probably familiar, but you've got 3 points of contact, critically important. Back of the head, he's holding a dowel rod. Back of the head touches the dowel. Mid-T-spine touches the dowel. Sacrum touches the dowel, right? So he's got a little bit of lordosis in his lumbar spine, lordosis in his neck, kyphosis in his T-spine, nice neutral spine position. And he just simply hinges at the hips while keeping that dowel at all 3 points of contact. If he loses one of them, if he raises this off his sacrum, then you know his spine is flexing. He's not using his hips. He's flexing his spine to get into the position, right? If he flexes his head forward and loses the head contact, same thing. He's using his spine to get into position. He's not isolating his hips. Slight bend at the knees, hip hinge to get on down, and that can be very therapeutic, right? Just to teach them small incremental progressions of mobility for the dowel deadlift like that. A prerequisite certainly before loading them. I want to see this nice cleaned up movement before I start loading their hips. All right, glute med, kind of higher level stuff. So you don't care about isolation anymore, right? We're at visit 6, and our 50-year-old guy with some non-arthritic kind of FAI is doing really well. He's done well with the isolated work, but we're ready to start loading him up now. The only way you're going to load somebody up and develop strength is by not worrying about isolation, right? So they're just almost like they oppose each other. Isolation and activation oppose each other. Activation would be total number of motor units firing, which correlate primarily to load, whereas isolation is trying to specifically fire one specific muscle. So anyway, the side bridge and plank, right, you can see is going to load glute med up a lot more. And you noticed earlier, it also loaded TFL, right? It also loads QL. It also loads the obliques on that side. So that's just kind of the price you have to pay to start loading them up and actually make changes. Single leg squat's a great option. The single leg deadlift, we're going to get into that. These are all really great glute med exercises to start loading people up. So just an advancement of that earlier side bridge. The earlier side bridge, he was on his knee was the contact point, or knee was the contact point. You're just elevating that to the ankle. And it's really important, I think, to get this top leg up like this. A lot of people will compensate with that right adductor, and you don't want that. You want them to really load that left glute med more than anything. Just slowing that side step down, there's some value to that. Actually, if you have one of those slide boards where they wear like socks, and then you know, just doing side stepping in that, having them then not have to pick up the foot, but slide that eccentric side back, real slow and controlled. Develop that eccentric frontal plane hip pelvis control. And then working that posterior lateral quadrant too. Posterior lateral quadrant is nice, right? That kind of back step out on that angle like that. He's getting his glute max and his glute med. Posterior fibers of glute med. So that's a nice kind of middle phase glute max, glute med exercise. And then progress your bridges. Progressing your bridges to a single leg and then eventually loading them. There's a lot of value in that too, right? And these can be endurance holds. These could be ones where you add perturbation, kind of like we did before. But if he's got to control, right, his other leg is up in the air, he's got to control his whole trunk like that with that isolated glute movement like that. That's a nice strengthening option. That's just the bridge with the perturbation right there. All right, now glute max higher level stuff. We're going to get into the step ups and deadlifts and those squatting type motions. This is such a great control exercise, right? The slow lowering is what most people have trouble with. So they can knock out reps of step ups, no problem at all. But when you have them try to do this slow sort of heel tap movement like this, they tend to struggle with that. So, you know, I want to see a nice, slow and controlled movement with a level frontal plane. And I don't want to see this pelvis drop on that right side. I want to see him keep his glute med the whole time as he drops down to tap his heel to the floor. And then loading that with dumbbells is a really nice way. You can actually make this easier by having him hold a dumbbell just in this hand right here. Kind of makes the exercise actually a little easier. But when he holds it in both hands like that, or even just the right hand, it forces him to really load that left. If you really want to load this left hip up, only hold a dumbbell on the right hand and a relatively heavier dumbbell. That's a great, in this case, left glute med exercise. A lot of people can't tolerate deadlifts. The form isn't that great, or you don't have the barbell in your clinic. You just don't have the setup for it. Anything you have could be a box of weights in it. A kettlebell works great. A dumbbell works great. But getting that weight between his legs is going to make it a lot easier. He's going to tolerate it a lot better. So the weight's between his legs, and now I can kind of progress that dowel deadlift to a loaded deadlift, making sure he keeps that nice spine position and really uses his glutes to extend his hips as he comes through. Loading the bridges is great. This is apparently just a picture, but if you have a barbell, right, this is just an easy little dumbbell option. If you have a barbell, though, having him lay the barbell across his lap for like a hip thruster type movement is probably one of your best glute max exercises. The kind of Brett Contreras. He's laying with his back on a bench in a bridge position, and he lifts his hips up with weight on his hips to really load that glute max. Not forgetting the core, right? Tons of planks, tons of plank progressions. I mean, sky's the limit with what you might do with the core, but all of your lumbar related exercises that you might apply to somebody with back pain are fair game for people with this non-arthritic hip pain, because you really want to develop control of the pelvis. So many people are going in for pincer lesion removals and labrum repairs, right? That's the big hot surgery these days, when all they really need is better control of their pelvis. That lesion was always there, right? I mean, that lesion is present in so many people with no symptoms whatsoever. They just have poor control of their core, and if you can improve that, usually you'll reduce the pinching. And this would be kind of higher level, like, so he's got that pinching pain, right? And I want to get him back to doing his activities. And so right before the point of pain, I can get him to do these chops and work his rectus and start flexing his hip and flexing his abdomen, and see how he tolerates that, and just progress that accordingly. And I don't want to totally avoid the painful movement, particularly in the end of rehab. I want to get him back to it. So this can be a nice sort of way to load the rectus and the hip flexors. And the last core one I'll show you here is this sort of FMS push-up stability movement, right? I mean, you can do a number of these, quadruped. You can do the one he's doing here with push-ups, but I just want to develop that core rectus oblique control. All right. Anybody got anything on that? I'm gonna keep going. I know we're running. We'll run long tonight, but this will be a resource for you guys to go back and watch later. So I'll just keep going. And I want to integrate a little bit of a case towards the end as well. But any questions at this point? Any other ideas or thoughts? Okay. All right. Relatively less severe injuries, right? Other injuries to consider, stuff that you'll see. Soft tissue injuries around the hip. What we used to always diagnose as greater trochanteric bursitis that we now know usually is not a bursa problem, usually is more of a lateral hip tendinopathy. And can you imagine the number of people that got cortisone injections, still today get cortisone injections of the greater trochanteric bursa for a misdiagnosed greater trochanteric bursitis, and all that cortisone does is wear down that hip tendon more, make the patient more susceptible to a glute med hip tear, which you're seeing with more and more prevalence these days. Gluteus medius tears are much more diagnosed now than they used to be. And so, does bursitis of the lateral hip exist? Yeah, sure. I'm sure there's a lot of patients that present with that. But I would consider that the tendon's probably involved as well. And so I usually will treat them with that mindset, right? The tendinopathy mindset. You can see the statistics there. This is kind of more a female disorder than a male disorder, but it's that lateral hip pain that kind of radiates down the leg sometimes. You get usually that specific tenderness right at the greater trochanter, and it's hard to discern between that and an isolated bursitis without imaging. I guess if it's swollen and puffy, maybe you're thinking more bursitis, but like I said, I still think that the tendon's involved. So treat it almost like it's a tendinopathy. Contractile provocation tests, if I have them abduct against resistance, right, that should light them up. I should see weakness with that abduction as well. The number one physical exam characteristic that correlates with glute med tendinopathy is Trendelenburg gait. Now this study is specific to glute med tears. Glute med partial and full thickness tears. Seeing that Trendelenburg gait is, I guess, a hallmark sign. A lot of these principles we used earlier are going to be key. Isometrics is such a foundational hallmark in tendinopathy management. Don't think of it as you're trying to get them strong, or you're introducing load through that tendon tissue to get a hypoalgesic response. And that's pretty much why you're doing isometrics, right? I want to get a hypoalgesic response. I want to possibly reverse the effects of muscular inhibition, get some type of a neuromuscular, activation. But big time, I want to reduce their pain, and it'll do that. So light, well-tolerated isometrics and isotonics. that supine hip abduction exercise we did in the very beginning with hip OA, that is a key go-to for me with these relatively old, not older, but like more deconditioned, kind of like middle-aged patients that have lateral hip pain that aren't able to tolerate much. Just getting them laying down in supine and doing the heel slide out to the side for abduction is key. Just a little bit of a manual therapy approach and a little bit of a light abduction approach. The mobility for them is an important one, right? So that I think with them, you just think like everything's going to get worse if they have less mobility, right? So if they have a loss of hip interrotation, I'm definitely going to address that with those manual techniques we did earlier and adding this kind of active movement, the self-move that I showed you earlier with Sarah's question, that kind of self-abduction, internal rotation movement is so key for these patients. This can be hypoalgesic for the lateral hip tendinopathy, kind of like a stretch that they feel like they need, right? Remember, they're not going into hip abduction on a regular basis, right? They're avoiding hip abduction because it's painful and maybe weak. They have a Trendelenburg gait to begin with, so they're collapsing into femoral adduction on a regular basis. They're probably losing some abduction mobility, and if you can kind of get them to sort of stretch out into abduction like this, that can be fairly helpful. Nice little light standing abduction movement like that, just heel, toe taps, TheraBand around the feet. TheraBand around the feet is really nice instead of the ankles because now I'm using the hip external rotators, and you have that glute med tendon where it comes in. It blends with the glute max tendon, and it has a fairly significant external rotation component to it. So I do want to load the external rotators, and it's a little bit more challenging, but putting the band kind of further out towards her toes is going to achieve that, right? So she's side tapping, not even side stepping, just side tapping while holding on to something like that. More side steps, again, around the foot is a nice progression. Maybe I don't start with it. Maybe I start with it around the ankle, but I like it around the foot. It's easier to get on and off their feet for one, but it also adds that extra rotation component, which is nice. Hip control with the step up. So when you're trying to fight that Trendelenburg, right? And they're doing well now, and you're doing okay with the loading. A little mini drop like this, and I can even make this an isolated pelvic movement where I just want that hip to drop down on that side just a little bit and then bring it up to isolate that right hip, that right glute med, and start to get them used to having to control that frontal plane pelvis position in space. All right, then if you get a specific posterior tendinopathy, that's like right underneath glute max, proximal hamstring, basically. You load that the same way you do in a hamstring strain prevention program or hamstring strain rehab program. So it's a lot of posterior chain loading, and you slowly progress lengthening, right? What lights these people up is when they flex the hip and the hamstring, the proximal hamstring tendon gets tight up against the back of the femur. That's what lights them up. So single leg deadlifts are a great exercise later on once they can tolerate it, right? Step ups are a great exercise once they can tolerate it. Probably initiate them with lower load, but lower excursion, lower amount of hip flexion type movement, right? Not nearly as much hip flexion. So like a bridge would be a great early one. A clam will be a nice early one. Just light extension movements that aren't loading the hip into deep hip flexion. Walking lunge would be a nice advancement. I mean, this is probably, like, this is one thing I always say, like, try to pick what's your favorite all-around exercise and why. That's always a great question. I mean, the right answer is always going to be it depends, right? It's case, depends on the case, depends on all these different variables. But I love the walking lunge for so many different people because of all the things that it achieves, right? I'm loading the posterior hip, so we're getting that nice posterior hip tendinopathy kind of loading approach. Loading glute max, working the quadriceps, working the frontal plane stabilizers with the glute med, but I'm also working hip flexion mobility. In this case now, right, so he's going to rotate out to the right. I'm working internal rotation mobility via the trunk, right? So I'm getting his trunk to rotate over his hip, which is creating internal rotation mobility with a flexed hip. I'm getting dorsiflexion mobility, stride length, like plantar flexion control, balance when he's up on the one leg. So it's such a nice all-in-one exercise that can give you so many different benefits. Single leg deadlift, hallmark to posterior hip pain. Hallmark exercise to hamstring strains, proximal hip tendinopathy. This is just your key control exercise. As he dives down, he has to control that hip eccentrically. As he comes up, he's going to contract that hamstring and load it in a lengthened position up to a shortened position. It's part of the FIFA 11. It's kind of like one of those key sort of exercises to preventing hamstring pathology, and very good towards the end of rehab as well. And then the Nordic cam curl will be the other big one, right? So loading those hamstring in a very aggressive fashion, having to eccentrically control his body weight as he comes forward, controlling the hamstring in an eccentric phase. It can be challenging for a lot of people. You can do an assisted Nordic ham curl. Strength and Conditioning Journal published a pretty nice paper on the assisted Nordic ham curl a couple years ago. They talked about all the different things you can do. You can have a walk down a dowel. You can put a strap around his chest and have a second person there to kind of help him down. But it is nice to get him to load this in the further, a little closer to knee extension, 20 degrees, 30 degrees of knee extension, as opposed to, like in this case, he's only really strong enough to hold it. So about maybe there was probably what, maybe 60 degrees of knee flexion, right? So he's not getting the full benefit of the exercise. You might consider assisting him a little bit in that case. All right. Questions about any of that? Glute tendinopathy. That's a good resource. Thanks, Sarah, for highlighting that. Right. All right. Well, I'll talk a little bit about this case and then open up for discussion and kind of get your guys' thoughts and stuff like that. So this is my kind of interesting recent hip case. So this guy, he's so I meet this guy at a like a fair, some weird event. I don't remember what the hell I was doing, but anyway, he's living on a sailboat in St. Augustine, right? And he's like telling me all about his injuries, and I'm like, trying to diagnose him in the middle of the fair, and then I'm like, you should come by the office. Let me take a look at it. So anyway, he comes in. 2 years prior, he is crushed launching a boat between the truck and the boat ramp. So see where that guy is standing? He's basically standing in that same spot. And the brakes fail on the truck and kind of pins him up against that ramp that's to the side. And he, like tibial plateau fracture. His tibia is actually what kind of got the brunt of it. But he also had some like hip pain immediately afterwards. Didn't get surgery on the hip. He just had the ORAF of the tibia. And this is like 2 years ago. So I take a look at him, and it's kind of a deep, constant hip ache. The knee actually is not bothering him at all anymore. It's this sort of anterior lateral hip pain that's kind of deep in nature. He's young, right? So, like, I mean, you're not thinking hip OA. You're thinking like there's some type of trauma that occurred to this hip, or the tibial plateau fracture has kind of given him some pathomechanics maybe that resulted in his hip pain. But he said that hip pain really hasn't changed over the past couple of years. It's kind of been constant. 4 out of 10. Definitely worse with walking. He gets it a lot with like when he's working. So he's working on his boat, he's moving stuff around, he's standing for long periods of time, and it'll get flared up after about 2 hours of that. It won't go away. His easing factors are not like, it takes a while for it to ease, right? He has to like either sleep it off or kind of take the rest of the day off for it to go back to that 4 out of 10 pain. See what else can I tell you guys about this from a history perspective. He's got no significant medical history. The tibial plateau fracture really was his main concomitant thing. He's not on any medication. He's a pretty healthy, fit guy. Really wants to get better. There's a pending legal case. He's suing the people that own the boatyard or whatever, and the trying to, I don't know, like the car manufacturer, whoever, whatever. There's a lawsuit going on, and he talks about the lawsuit constantly. So that's part of it. But what else do you guys want to know from a history perspective? Or do you have, what hypotheses do you have just with that basic level of information? Good, chime in.
I assume you cleared the lumbar spine.
That's a good question. Well, all right, so we can get into physical exam. So physical exam. So anyway, well, all right, before we talk about that, so from a history perspective, yes, he has no symptoms in his lumbar spine. He has no symptoms anywhere other than the anterior lateral hip. What hypotheses do you have based on that, or is there more information that you want from a history? We'll get into the physical exam. Ags and eases are walking. If he's like walking around town, he's got no car. They live on a boat. So when he walks around town, he gets it after about 2 hours. When he's working on his boat, standing, lifting stuff, moving stuff, he gets it. It definitely is worse towards the end of the day because he's pretty active. Ease is only really with sitting, but he really says he kind of needs to go to bed, take an ibuprofen, and then when he wakes up, he feels better. But he can't like sit down and make the pain go away. Lumbar and hip are both on the table. Yeah, that's true. Even though it's not that region of the hip, right? Certainly could be, being referred from the lumbar spine. Hip flexor irritation is definitely on the table, right? I think that's a good one. What hip conditions would you guys are like at the forefront of your mind? Now, I guess I should give you more like MO. As he's pinned against it, he had the hip pain kind of right away, right? So it's not just a result of the tibial plateau fracture. It's like with the trauma of the thing. Morning symptoms versus rest of the day. He did not feel bad in the morning. He felt pretty good. He is much worse with activity as the day goes on. No vascular compromise, Ashley, that's a good question. You mean like because of the tibial plateau fracture? He didn't, that was a like barely operable type of thing. And he had imaging on the hip. So you could be right, maybe it's a stress fracture that was missed on imaging. But he did hang it up for a long time, right? With the tibial plateau fracture, he was basically, doing nothing for like 4 or 5 months, 6 months. He had rehab early on at some point, but not much. Lateral hip anterior. It doesn't go down his thigh very far, though. It doesn't go down his thigh. It really stays kind of in that hip region, the proximal third of the femur. possible glute tendinopathy is good because you picture like he has the trauma where the side of his hip, rams into the ramp or whatever, and maybe that just created a sequela of lateral hip pathology. SIJs definitely could be in it. I mean, it's a pretty high energy trauma case, and certainly SIJ is on the table as well. I think you guys are all thinking in the right direction. So like, and then the one thing, I always kind of was wondering with it was just like, is it some type of, because he has that weight-bearing pain that's worse as the day goes on, and I'm just always kind of like, is there some type of non-arthritic hip pain? If it's a synovitis, maybe he has some type of osteochondral defect, right? You can get little cartilage tears in the head of the femur that can give you those kind of symptoms, maybe some type of even FAI or something like that. But all right, so the physical exam, so going on to the physical exam, he is, well, first of all, knowing that, what do you guys think about severity and irritability? And then we'll talk about the physical exam. No, he doesn't do any real exercise. He's living on a sailboat, not doing much exercise. No resistance training, not at all. Not at all. He's like relatively sedentary. I mean, doing stuff in the sailboat, but no exercise. High irritability. Symptoms have not progressed over the past 2 years at all. The pain is not that debilitating, actually. He described it as a 4 out of 10 kind of constantly. It'll go up a little bit. 4 out of 10 pain level, it'll go up. I can't remember exactly what he would say it would go up to, but it would go up. But he's still pretty active, and he still can kind of do everything, right? It's not like it's one of those things that's sort of bothering him, but not really killing him. So moderate severity, high irritability, that makes sense. That definitely makes sense, right? High irritability primarily, why? Why do you say high irritability? It takes all night for it to go down. Exactly. Yeah. Once it gets flared up, it really does take a long time to go down. So that's key. I think you could make an argument for minimum moderate severity, right? I mean, he's kind of like a gritty sort of tough guy pushing through things anyway, and it doesn't seem to me like it was really affecting his quality of life all that much, more just like annoying, and he wanted to see if there was something that could be done for it. So you guys are definitely on the right path there. And we had a number of hypotheses that all sorts of things that needed to be explored. His lumbar spine was totally clear. So I screened the heck out of his lumbar spine because he had a history of back pain. I think I forgot to mention that earlier, the history of back pain. Lumbar SIJ, totally clear. No radiculopathy either. Slump test, straight leg raise, all that stuff clear. No real neuroscience whatsoever. We get in there and start provoking the hip, and he does not test positive for any of the FAI tests. So I can grind that hip up into hip flexion, and it doesn't really do much to him at all. Even when I palpate for tenderness on the lateral hip, the glute med, not really much at all. Contractile testing really doesn't do anything at all. So I really had a hard time reproducing his symptoms until I had him single leg deadlift, single leg squat. When he loaded that hip on one leg, first of all, his mechanics were all over the place. Mechanics did not look good on that leg compared to the other one. He had so much quad atrophy, probably because of that tibial plateau fracture, really poor quad control, poor glute control, and it reproduced his symptoms when he loaded it on that side. So from a pathoanatomical diagnosis, I mean, it's still hard to say. Does he have a synovitis, some type of chronic subchondral bone edema? It's hard to say, but you do know what you need to work on, right? You do know for sure that he's got pathomechanics that are going to definitely lead him down a sequela of DJD if they aren't addressed, right? So that's really the eval in a nutshell. What do you guys what do you guys think about spine control, right? So in other words, when he squats, he flexes his lumbar spine like crazy. He has sort of aberrant movement of the spine with active movements. He can't really control his abs at all. He can't sustain. He could hold a plank for like barely 6 seconds, right? Really challenging that compared to his glute control, compared to his quad control. What order are you going to address his exercise prescription? Are you going to tackle it all at once, or are you going to sort of, I guess, sequentially chip away at that? Proximal to distal. Why, John? That's a good. I mean, that makes sense. But why? What's your logic behind that? Alan, you like supine to standing weight bearing progression. So Alan, you're going all at once. John, you're doing more of a proximal to distal approach. What's the rationale? Why one of those versus the other? Proximal distal control 1. What's DOF? Degree of freedom. Nice. So focus on one aspect at a time, right? Proximal distal control. You know what's kind of neat? So I feel like core lumbar control will help with glute control and into the quad. That's solid rationale. You know what's kind of neat with that is you can address his proximal issues and see if that cleans up any of his distal movement stuff. And that's what's kind of interesting with this guy. And that is definitely, so I'll tell you the mistake I made. I tried to really isolate his glutes early on because it made sense to me. I was like, oh, he's got glute weakness. He's got all this hip pain. And I did like this kind of gravity eliminated, like, oh, I see what you mean. Gravity eliminated, see if the distal motor control issues resolve. So see kind of from a load perspective, can you improve the movement? But I did a lot of the low level glute stuff and it didn't help at all. And I would say the first 2-3 visits, I kind of really focused on that. It didn't really see much progress. I mean, he was doing the exercises and they were helping to some capacity, but I wasn't seeing any movement improvements, any movement changes until I addressed his proximal stuff. Once I got him doing a lot, I got him doing planks at up to like 1.5 minutes, and he's doing all the core rotational stuff, doing like the lunges with the trunk rotation and all that kind of stuff. Once I started really getting into all that is when his squat started to look a lot better, his deadlift started to look a lot better, and his gait started to look a lot better. So I think for him, early on it was like bridges, clams, and straight leg raises, which almost did nothing for him. So I think what the lesson I learned, like he wasn't high severity, right? He could tolerate all that stuff. His pain level wasn't all that high. And even though we considered his irritability, right, to be like a little bit more on the severe side, he's still able to tolerate exercise, no problem at all, right? It's the long duration stuff that he can't tolerate. So I think the lesson I learned there is you definitely should and can start more aggressive, right, sometimes, and clean up a lot of the issues that you otherwise are just wasting time with, I think, in the isolated low-level approach. Other thoughts and questions on that? All right. Well, I will be available for you guys. Like I said, I'll check Facebook a lot over the next week. I'll make sure that I have the notifications. Oh, what kind of HEP did he have? So, all right. So one thing that we did a lot of because he liked, so he's living on a boat, right? He's living on a boat. But he had like sort of TRX kind of type of thing that his wife was using on the boat. So they were like tied to something on the boat. So I had him doing squats with like the TRX, and he really liked that a lot. And that seemed to help his squatting mechanics quite a bit, and so that was one thing. Early on, I did the low-level stuff. That was his HEP. Once he progressed, it was more the TRX squats and then kind of like deadlifting movements. I think at one point I had him doing like dowel deadlifts, but then eventually like loaded deadlifts with weight between his knees. But saw that guy for maybe 10 visits, 11 visits, and he did really well. The pain completely abolished towards the end of therapy, and then I haven't seen him. I haven't followed up with him in a while, but I tend to not really like discharge patients. I tend to just kind of like see what kind of improvements we can make, and then usually try to have them connect with me 4 or 5 months down the road, see how they're doing, and just check in and go back and forth. I really want to be everybody's family physical therapist. That's like my goal. I want to be your family physical therapist. You come in, I'll take a look at you every now and then, see how you're doing. I want to sort of treat everything. I want to treat your shoulder pain. I want to treat your ankle sprain. When your kid gets hurt playing lacrosse, I want to see your kid. Like, I am your family physical therapist, and that's really the way I want to try to develop relationships with people. And you got to look at, you ever wonder why when people say, like, they talk about a lawyer, yes, twice a year, make sure you floss. When people talk about a lawyer or a chiropractor, they say, my lawyer. You ever notice that? And they say it with, like, pride. Like, if you don't shut the hell up, I'm going to have my lawyer call you, right? They say it with pride. Or, my chiropractor makes my back pain go away. Like, they are very passionate about describing this, like, relationship they have with this professional. I've never heard somebody describe a PT like that. I've never heard somebody say, my physical therapist. Yeah, my PT tortures me. But they usually say, I had physical therapy. I got physical therapy over at this clinic. They don't say, like, Dr. Britt Laidman, my physical therapist, right? They don't say it that way. And so whatever you can do, your primary goal, like, to me, the primary outcome measure is that they, like, refer to you as, like, my physical therapist, and that they call you when they have a subsequent pain or injury later going down the road. And then they refer friends and family to you. That's the number one metric. Number one metric is that you get a phone call saying, man, my buddy John, he said that he saw you a couple years ago for his back pain. He told me you're the person to see. You're doing things right if that's happening. And if it's not happening yet, it's just because you're too new in that town or you're young, but in time it will. If you're doing the right thing, it definitely will. So, all right, you guys. It was fun. Like I said, check Facebook, get you guys any resources. I'll post the PowerPoint. I'll give this to Alan so he can get it to you guys, because all those exercises had, like, descriptions and dosing parameters next to them. So definitely get that. Awesome. Thanks, guys. Thanks, everybody. I will catch you guys later.